So hello and welcome. Thank you for joining us today as we honor our veterans on Veterans Day. My name is Karen Eggleston. I'm director of the Asia Health Policy Program at Stanford's Freeman Spogli Institute, our Asia Pacific Research Center, and delighted to welcome you to our COCIM series. This academic year, our theme is Aligning Incentives for Better Health and More Resilient Health Systems in Asia. Delighted to welcome a very special keynote guest speaker today on Indonesia beyond COVID. Before I introduce her, I just want to mention some of our forthcoming events. Hopefully, some of you will be interested in those and can find more information on our website. In just a few days, on Tuesday, on November 16th, we have the health impacts of climate change in Asia as part of the APARC series. On January 10th, we have a panel on demographic change in China. And February 17th, a special panel on measuring the value of medical spending. So hope you'll be able to join us for some of those. Please look at our website for further information. Today, we're delighted to welcome Professor Vivi Alatas, an economist with a passion for evidence-based solutions. She is CEO of Asakreativita, a consulting and Edtech company that she established last year. Formerly, she was a lead economist of the World Bank, where she led a team of seasoned local and international economists in producing several flagship reports for national and global audiences, including Targeting Poor and Vulnerable Households in Indonesia, Indonesia's Rising Divide, Aspiring Indonesia, Expanding the Middle Class, and others. She has presented various of these research findings to the president, vice president, ministers, deputy ministers, and others. She has also written several journal articles on poverty, inequality, and labor issues. And some of those academic papers were written in collaboration with Nobel laureates Abhijit Banerjee and Sir Angus Deaton, who was also her advisor at Princeton, where she earned her PhD. If you have questions for Dr. Alatas, please type those in the Q&A function in Zoom, and we'll discuss your questions later in this webinar. So Dr. Alatas, thank you for sharing your research and policy insights with us. Over to you.
Thank you very much, Karen, for inviting me. It is an honor for me to have a discussion with you about Indonesia experience. Let me start with sharing my screen. Thank you for the opportunity. I want to share Indonesia's challenge in protecting vulnerable households during the pandemic and the lessons learned. To date, the total recorded COVID cases in Indonesia are around 4.2 million cases. In June, July 2021, Indonesia experienced a drastic spike in COVID cases. This is after Idul Fitri holiday. The positivity rate in Jakarta reached up to 47%. Hospitals could not serve the influx of patients, even those with critical condition. As a result, the number of deaths among self-isolated patients increased sharply. Throughout the pandemic, 2,032 paramedics, doctors, nurses become victims. This health disaster also impacted various other problems, such as rising domestic conflicts, increased anxiety, depression. At least 64% of women surveyed from participants of the Fed Facility Program to Empower Women, called Mampu Program, reported experiencing at least one out of the various health issues listed in the screen. The economic impact is also real. An extensive survey conducted by UNICEF, UNDP, Prospera, and Smeru showed that 3 out of 4 surveyed families experienced reduced income. Half of the family did not have saving account, and 9 out of 10 family business were affected. The good news is that the storm seems to have subsided, and we have more hope to see the end of this pandemic. On July 15, 2021, new active cases reached 56,000 additional cases, but by the end of September, the number was just 2,881 and continued to decrease. Likewise, the death toll became much smaller, and the number of active cases fell drastically. Another good news that this is happening everywhere, not only in Jakarta. You can see from the graph on the screen, the new active cases come back to prior to the spike. And even for some areas, it's even smaller than that. Similar story for number of deaths. and similar pattern to the total active cases for each province. In some areas, the number of active cases was already lower than the figure for June 1st, 2021 before the sharp spike. We also got hope from seeing a drastic decrease in the bed occupancy ratio in hospital when comparing June 30 data with November 5th data. Jakarta at one point had a bed occupancy ratio of 92%. No, only has less than 5% bed occupancy ratio. Food shortage also decreased from 32% to 26% and then continued to decrease slowly to 22%. But of course, 22% is still a significant number. There are still a significant number of households that needed help. We need to examine what factors causing the flattening of the COVID-19 curve. Why is this important? We cannot say for sure whether this pandemic will disappear soon or there will be a second or a third wave like what has happened in other countries. Therefore, learning from what is happening is very important in determining future steps. Many factors may contribute, and it is not easy to pinpoint which one is the dominant factor. Is it because of vaccination? Is it because of restriction policies? Is it because of reduction in mobility? Is it because of community compliance? Or are we approaching herd immunity? Frankly, I cannot really give definite answers to this question. I can only show statistics that might provide insight. Indeed, there has been an increase in the administration of vaccines in the last month, with 100% of medical personnel and public officers having received the complete dose. But the elderly, who's supposed to be the #1 priority, less than 50% of them get the first doses. So vaccine help, but I'm not sure it is the dominant factors. There is also, if you look, regional disparity. Jakarta has reached 132% because residents with identities from outside Jakarta also get vaccine in Jakarta. But Papua, Aceh, and Maluku are still far behind for first doses, let alone second doses. What about social distancing policy? Indonesia has never really done what is called a lockdown in other countries, but Indonesia has some policy to reduce mobility. It's quite complex policies, starting on 31st March 2020 with the so-called PSBB policy, which is head of region can submit requests for mobility restriction to Minister Referral based on eligibility criteria. And the request is usually for 2 weeks and then can be extended. Then in January 2021, government changed the restriction policy for Java and Bali, focusing on work from home for certain sectors, restrictions on operation for mall, religious gathering. And in February, the policy changed to all over Indonesia, but call it PPKM Mikro, not only for Java and Bali, but the restriction is at the neighborhood level, based on the number of cases in the neighborhood. Then in July 3rd, 2021, as a response to the spike, government introduced PPKM Darurat, which is a more restrictive compared to the previous policy. After that, each provinces then can graduate to level 4, 3, 2, 1 with less restriction based on the number of cases. So these policies indeed create mobility is indeed declining. We can see from Google data. But is this the main factor? I'm not sure, especially if we look in terms of like this mobility is declining, but we can see a lot of non-compliance, anecdotal evidence of a lot of non-compliance. We need further and more thorough studies to understand the impact of these restriction policies on the cases. One interesting result is the Jakarta Serology Survey conducted in March 2021 by Faculty of Public Health, University of Indonesia in collaboration with Jakarta government and Eijkman Institution. This data showed that in March 2021, 44.5% of population in Jakarta were positive, having a positive antibody. even though only about 3% have had positive PCR or antigen results. And vaccination was just started, so it cannot be because of vaccination. The age group with the highest positive result was 30 to 39 years old. You can see also that the positive result were relatively high even for toddlers and teenagers. This survey was conducted before the spike after Idul Fitri holiday. So it is plausible that the number of this positive antibody could be even as high or higher now for other places after the spike as well. It could be that far more people have been exposed to COVID but were not detected. Currently, surveys for other areas are being carried out but not yet completed. So the storm is not over yet. We need to be prepared for all eventualities, taking into account what happening in other countries with second wave or third wave. We cannot afford to re-experience what happened during the spike in June to August. Oxygen scarcity, near collapse of hospital, rapid increase in the total number of deaths. Anticipating a surge in mobility during the end of year holidays, we need to face and overcome the following 4 challenges. The first challenge is addressing uneven public service delivery. Indonesia is an archipelago with more than 18,000 islands. Delivering quality public services anywhere in the country was a significant challenge, even before the pandemic. There are regional disparities. Surveys conducted by the Ministries of Health show an improvement in the distribution of the ratio of health workers in several provinces, if we compare data in 2018 with 2013. However, as you can see, still there is significant homework to overcome regional disparity. Likewise, Puskesmas, the local clinics, level of readiness portrayed similar story. In 2019, the average Puskesmas had 79% of the facilities and supplies needed to perform their function, an 8 percentage point increase compared to condition in 2011. We also observe regional disparities. There is also urgent need to continue to improve the skills of Puskesmas staff. Only a few have received important training, such as training on addressing infection, tuberculosis diagnosis training, and various related training based on 2019 health risk survey result. The role of Puskesmas during the pandemic can be improved, can be quite critical in carrying out various interventions, such as public education, tracing, testing, vaccination, referrals, data collections, and monitoring. It is essential to ensure that Puskesmas throughout the country are ready. But there are many commendable interventions that government did to improve the public services. Indonesia, for example, is increasingly using data and technology in providing services and information. Data and information are easier to find. We can easily access Corona information dashboard. We can use online submissions for vaccination or checking other information. Hopefully, the usage of this data and technology will continue and will be further improved after the pandemic. So in the future, there are several priorities to ensure that Indonesia can be more prepared no matter what happens. The priorities are empowering Puskesmas role as the first point in services, establishing shelter for self-isolation need in every kelurahan and village to anticipate a spike in cases, improving real-time data dashboard about the availability of beds, and also monitoring system for home-treated patients. We need to have those things to ensure that Indonesia can address whatever happens in the future. The second challenge is to protect vulnerable families from health economic shocks. Disasters is not a new thing for Indonesia. Within the last decade before the pandemic, there were 18,000 small and large disasters in various parts of the country, with 6,000 fatalities and up to $16 billion losses. As a result, poverty is very fluid in Indonesia, with 50% of the poor each year being new poor. People exit and enter poverty. Not only poverty, people also exit and enter middle class. It is not easy to climb up the ladder. Within 14 years, this is based on our research when I was still with the bank, almost half of the aspiring middle class remain. 26% became middle class, 24% of the middle class became aspiring middle class. People exit and enter middle class. Poverty indeed increased during the pandemic. Previously, it was only 1 digit, and now it is back to 2 digit. Increased by 1 percentage point from 9.2 in September 2019 to 10.2% in September 2020. Compared to 2019, there were 2.8 million additional poor people in 2020. To help the poor, the government increased the allocation of social protection program from 0.8% of GDP in 2019 to 1.5% of GDP with total budget of 220.39 trillion for various existing and new programs, such as conditional cash transfer program, program Keluarga Harapan, in-kind essential food transfer, training program, program prakerja, electricity discount, and many other programs. A simulation study conducted by the World Bank showed that if there were no various assistance, poverty would have increased by 2.3% instead of just 1% as we see in the previous slides. So this increase of allocation helped the poor to overcome the economic shocks. But COVID-19 is not over yet. Going forward, the priorities are continue to ensure sustainable allocation that can help poor and vulnerable families. The hardest hit is not just the poor, but the bottom middle class. Integrate various programs into an adaptive social protection system as needed, and link some of the program with conditionality to increase health compliance. And of course, we need to improve tax collection through tax reform to ensure fiscal sustainability. The third challenge is reaching out to vulnerable households. The program impacts depend not only on the size of the benefit, but also on the accuracy of the target. Indeed, there were obstacles in reaching vulnerable families at the beginning of the pandemic because the targeting data was not up to date. It was collected in 2015, and the coverage did not include the affected bottom middle class. There have been some improvement over time. The central and local government combined various data and programs to target the beneficiaries. At the end, around 90% of the bottom 40% received one type of any kind of transfer, at least one type of transfer or one type of assistance. However, if we look at the programs one by one, there are still quite significant exclusion error. For example, the conditional cash transfer program, only about 40% of the bottom 20 get the program. Indeed, it is urgent to improve the targeting system. But it is not easy to establish and maintain a targeting system in an archipelago, the fourth most populous country with a high degree of poverty vulnerability. We also need to take into account path dependency and get buy-in from various stakeholders, local government, parliament, community. Developing and updating targeting system requires data collection and selection decision. Collection method is needed to determine which household to be assessed. There are several choices: geographical targeting, survey sweep, community, on-demand application. And the selection method is the screening tool used to assess the household and decide the beneficiaries. There are several choices: mean testing, proxy mean testing, categorical, community decide, or automatic eligibility. What are the best ways to improve both the collection process and the selection process to ensure that our targeting systems is up to date? There has been quite a lot of studies dedicated to getting more insight into answering that question. Is community better than proxy mean testing, for example? Will there be elite capture? Our research indicated that PMT had the lowest rate of mistargeting, but the community is better in identifying the very poor. In a nutshell, lessons indicated that we should use a hybrid approach using both communities and PMT. The research revealed no evidence of elite capture when we ask a group of elite versus the whole community. It is also showed involving communities translated into higher satisfaction and fewer complaints. So the goal is not just to improve for the time being only. There is a need to ensure that the targeting system is continuously maintained and used. It is not just about now. It is more about ensuring Indonesia can react quickly anytime. It is therefore essential to have an on-demand application system for continuous improvement where everyone can apply anytime. Lessons from other countries show on-demand application had good results. We can quickly increase coverage as needed. For example, currently, the on-demand application can be offline or online, and technology can help to make it available anytime and to verify with other data to reduce inclusion error. So going forward, there are 4 priorities to ensure that Indonesia is ready to reach its own poor and vulnerable, whatever the shocks and calamities. These priorities are as follows: setting up on-demand application, linked with other data to verify, involving community with clear standardized procedure, improving the data and model for proximity testing by also using spatial and utilization data and better model. The 4th challenge is inducing crucial behavior. The primary weapon in dealing with COVID is ensuring behavior change and compliance. Since the beginning, Indonesia has campaigned for the importance of 5 behavior: wearing a mask, washing hands, keep the distance, staying away from the crowd, reduce mobility. But the compliance were quite low in some areas. This is an example of non-compliance in keeping a distance and avoiding crowd. Indeed, there are punishments such as being ordered to sweep the streets and fines, but the monitoring was not optimal and the threat was not that credible. This year, the government banned the exodus during Idul Fitri, for example. But what happened was they went back to their kampung before the ban was enforced. We can see this from these pictures. There were some protocols about religious gathering, again, with significant non-compliance. The Mampu survey at the end of 2020 that I mentioned earlier tried to see the perception and willingness to follow the health protocol. Only about 18% stay at home. More than 50% still conducted, for example, visiting friends, wedding, restaurants, or recreation. Compliance of wearing masks was better. Why are people not willing to comply with critical behaviors? Why do people misbehave? There are many possible reasons: economic needs, cognitive biases, hoax and lack of knowledge, lack of credible punishment threat, for example. Let's try to see, of course, like I don't have the whole data to really understand better in each of those factors, but there are some indication. Discourse on the impact of pandemics tend usually to contrast the health impact and the economic impact. And this can be seen from the results of the Mampu survey. Around 17% stated they were more afraid of the economic impact and the health impact. And also a quarter felt that the number of victims was less than the government data. There was also a problem of lack of knowledge. When asked about the symptoms and comparing data, many respondents still did not have the correct answers. For example, 70% cannot answer correctly about the symptoms and the comparisons with the influenza, and 33% have the wrong impressions regarding the total cases. One of the cognitive bias that can encourage non-compliance is the overconfidence bias. Around 81% felt they were unlikely to be affected, and 62% were optimistic that the pandemic would end in less than 6 months. The survey was conducted November 2020. Another critical behavior is willingness to get vaccinated. Survey conducted by Saiful Mujani research company showed that on December 2020, 57% were reluctant or undecided about getting the vaccine. And the World Bank survey also examined the same issues. It turned out that most of them were afraid of the side effects or the vaccine safety. Indeed, one of the triggers of doubt and reluctance is the rise of hoax. The Ministry of Information found 109 1,977 hoax related to COVID from January 2020 to November 2021. Of course, this number is an iceberg of tip of the phenomena. WhatsApp is a massively used application in Indonesia and is the primary means of disseminating information, often without checking and rechecking at first. The breakthrough made by the community, there are some actually. For example, Mavindo, Wittenberg Hoax Program, Hoaxbuster page from the Comindo, but addressing hoax, a wicked hard problem, not only in Indonesia and also in other countries. Understanding the reasons and what works and what doesn't to address it is still a long way. We don't know much about it. When the vaccine programs launched, the government relied on using celebrities, influencers to encourage more followers. But it turned out to be, you can say, a backfire. Raffi Ahmad, a celebrity who has millions and millions YouTube subscribers, was invited to be the first to get the vaccine along with the president. On the same day, pictures of him partying without a mask after getting the vaccine became viral. Messengers matters, but it is necessary to examine which messengers is suitable for the message you want to emphasize. When asked who do they trust in getting the right information, 71.5% said doctor. Only 0.9% replied YouTuber or a celebrity. The leading actor in overcoming the pandemic is the community. The good news is that many community efforts have succeeded in using their social capital. For example, the Sonjo effort in Jogja. Sonjo is using WhatsApp group to address grassroots level problem through sharing knowledge, crowdfunding, facilitating collaboration, and improving capacity for coordinated actions. For example, they have Etalase Pasar Sonjo, showroom app for SMEs. Sonjo Husada Tangguh, collaborative fundraising to support shelter. Sonjo Migunani, sharing knowledge through webinar, for example, how to establish a shelters. Sonjo Pasar Desa, supporting logistics to patient in shelter. Sonjo Saras, volunteers to supervise shelter. Sonjo Uwuh, medical waste management for shelters. Database of patient in shelters, monitoring the shelters, and also volunteer for funerals following the health protocols. Sonjo is not the only good example of community efforts. There are many other examples. There is a need these positive defiant stories be replicated elsewhere. So once again, COVID-19 is not over. We need to prepare for whatever will happen. There are various efforts to encourage behavior change. Still, an evidence-based approach is required by conducting further studies on the underlying cognitive bias and the appropriate way to promote behavior change. Other priorities are encouraging more expansion of success stories such as Sonjo and using technology for tracing and nudging. COVID is our common enemy, and we need a concerted effort to overcome it. Thank you.
Great, thank you so much. That was a very rich presentation with lots of information for people to digest. For all of our listeners, if you'd like to ask any questions, please put those in the Q&A, and we'll get to those in a minute. So I wanted to start us off by asking you about some of the things that are related to our theme about aligning incentives. You brought up several issues with that. One, you mentioned the importance in protecting the vulnerable and improving targeting about, for example, using conditionality and bringing in multiple stakeholders. So I wanted to invite you to give you a few more minutes to talk more about why you think that's important, conditional on what, and what would improve the alignment of incentives for reaching the vulnerable and improving targeting.
Yep. As you see, Karen, like Indonesia need to expedite the vaccination process. One of possibilities is like having conditionality linked to vaccination. You say you also saw earlier in the one of the slides, it's like there are still some reluctancy and people are still undecided. Like you also have like 50% of the elderly not yet getting vaccinations. So having the cash transfer program, either like a social assistant linked to compliance in vaccination, or even like another possibilities is also having Indonesia have this health insurance program called BPJS. It is still unfunded, like a lot of like moral hazard problems, where people only apply when they need it. So linking it to conditionality of having this BPJS, being a member of BPJS could be another good conditionality to ensure that not only now, but later on, Indonesia can afford to provide good health services for all. Those are the two things. I think, of course, the other one is like possibilities like making sure that the compliance is not credible threat and monitor effectively so that it have some impact later on when they have to use the social assistant or when they have to use the hospital, for example. Currently, Indonesia have better program and better data to monitor the usage of services and also vaccination. You can use it. And also, I think there are possibilities to use technology to do more tracing to ensure compliance on some of these crucial behaviors also.
Great, thank you. So actually, one of our first webinars was related to a randomized control trial in Bangladesh. I don't know if you heard of the norm study that looked at trying to nudge people or to promote the norm of wearing masks. And so the end for that related to no cost distribution. So I don't know if you think that's an important issue. I mean, there was also modeling that behavior. You've done work on celebrity endorsement. So both in terms of mask usage and vaccination, where you've done other interesting work about the messaging. What do you think are the lessons learned about what works in that respect?
One of the interesting one, especially this is like also on vaccination, is in the beginning, the priority is actually for elderly. Then government to induce, like what happens, like you don't really see much elderly come to the vaccination places. So government tried to nudge by having, if you buy 2, you get 1 for free. So for those elderly who came, 2 elderly came together, they can bring the non-elderly with them, which is at that time is not yet eligible. So for example, I got my vaccine because I bring some elderly with me, 2 elderly with me, and I can get the vaccine. And that's quite able to actually induce people to have vaccination. But of course, like really understanding, like as you see earlier, messengers matters. Indonesia did need to do more of doing nudging, but the messenger should be more doctors, someone who has the credible authority to ensure, because like the main worry is about health impact. One of like the main issues was like there is a perceived belief that pregnant women shouldn't get any vaccination. Of course, it is not right, but there is a need to ensure that people understanding better. They will have more belief if it is coming from someone with authority. We need to have more bidan, the midwife and doctors, be the ambassadors of these good behaviors.
Thank you. Yes, a lot comes down to trust, right, of the messenger and the message. Yes, totally. And it's very interesting and I guess encouraging that you would say that healthcare professionals would be ones that would be trusted in this case. It's a natural assumption, but then one does see there are cases where that's not true. So for example, in your own vaccination study, I believe you found that celebrities, when they retweeted supposedly authoritative sources, that it didn't end up having So maybe you could talk a little bit about what you found in that study and then
So
why, yeah, go ahead.
yeah,
Mhm.
no. Those studies look at the immunization. Indeed, like we use Twitter to encourage this is like a randomized control experiments. Like some of the tweet comes from celebrities, some of the tweets come from the non-celebrities, and indeed celebrities not only because they have more followers, they have the tweet. This is about immunization of for toddlers. And the tweets from celebrities were more forwarded, retweeted, and we also saw some impact, outside impact of the tweets and better understanding. And this is an interesting because we don't really see because in the beginning, the Indonesia did a lot of using these celebrities, but we did not see some similar answers. Of course, it might be possible that it is still have some impact in terms of disseminating the informations, but the message are different. So it's difficult to pinpoint that it is what happened in our study should also happen in this current situations, because our studies is about some immunization issues and also not about death and life issues, and it's not everywhere. But I think our studies indicated that Twitter and celebrities can be a way to disseminate knowledge, but taking into account the current difficulty, we cannot really just rely on that particular ways of nudging. We need to induce the behavior, and the messengers are not only from one side. Like, for example, in some cases, it is clear that people are worried about people wait and see from their neighborhood, from their friends. And once there is a testimony and clear that it is okay, and some of their friends already did it, you see it's like a better you see more willingness to do it. You can see that from some of the anecdotal evidence from some other some areas. After a while, you can see it's like more response to conduct, for example, vaccinations.
Right. I wonder, I know it's not your own primary focus of study, so feel free to defer, but I had a question related to your fourth point, actually, which was related to the puskesmas, right? And the uneven public service delivery. So as you said, those trusted messengers often are medical professionals, but then there are many areas, such a large archipelago nation, and there are many local communities where the local providers are not as well trained, but they might be much more familiar to the community. So in one sense, they're more trusted because they're local, they speak a local language, but they might not have the same amount of training. So I wonder about your thoughts on that kind of trade-off when we're trying to think about trusted messengers in a pandemic or any other emergency response.
I think there is a need to have more referral system. Some of the issues, some of the frequently asked questions, some of the worries, like midwife and in Indonesia, in each of neighborhood, you have this PKK, the cadre who come to talk about the dengue fever and etc. You need to ensure that they know better about some of the basic information. For example, the symptoms, where to go, when to go, is it a severe symptom versus you can do self-isolation at home. This is something that I think midwife and these local cadres can do as well as doctors. But some of our other issues, for example, like comorbidity, should I do this? Should I take this vaccine? What will happen if I have diabetes and others? Doctors might be the one who will have a better track in terms of inducing, convincing them to take the vaccine, to be willing to do the compliance of all of those activities. So it depends on the messages, but I think you need to have all level. For example, this is also important to ensure that shelters have the capability to do the easy services so that to ensure you don't have influx on hospital. So ability to screen information and screen action when to go to shelter versus when to go to hospitals is very much needed if we want to make sure if there is knock, however, if it will not happen, that a second wave or third wave. So I think there are roles for puskesmas, local cadre, and midwife to disseminate, to nudge informations. But there are also roles for doctors and others, and including religious leaders. I think religious leaders can be used more because they have like either in mosque or in church, they have everyday, they could use their ability to convince, to talk about like the importance of this compliance also.
Yeah, that's a similarity with what they found in the Bangladesh study also. Fascinating. So you mentioned that there are so many different factors. It's hard to tease out sort of direct causal impact of any one of them, of course. But I wanted to ask you further, what is your impression about the longer term impacts of the current crisis? And since we were just talking about healthcare providers, maybe we could start there. Do you think that what has been the image of sort of the health system and working as a healthcare provider, has that been impacted by the crisis? There will be more people, fewer young people interested in serving. As you may know, this has been controversial in many countries. Who goes into public health, who serves in healthcare, who have been the victims? One of your first slide pointed that out. But the importance to society of building a resilient system rests partly on the human capital of those providers, right? So what are your thoughts about the longer term impact of this kind of crisis and response?
Yep, I think like two type of impacts, like first on the healthcare providers itself, like as you like as we see in the first slides, like Indonesia probably have like higher proportions of victims among healthcare providers compared to other countries. And in the beginning, we do not even have that much in the first, like some of the slide. We need to have, even before pandemic, we need to have more doctors, more nurses, and we have like regional disparities among those. I'm worried, like indeed, Karen, I'm worried, like some of like those, it's not easy to have like more doctors, especially specialized doctors. Like you need years to ensure, like this is something that we are worried. That's why I think like the inducing healthy behaviors, inducing willingness, preventing mechanisms will be even more important. And I think like nurses, like having a more focus on catering, like producing like more nurses and also better paramedics and midwives at the local level is very important. The other things that I'm worried about is the impact of hesitancies to do other things, like for example, vaccinations for children. There is like some of the studies and some of the survey showed some impact in terms of reluctancies to conduct vaccinations. So I'm worried that incomplete vaccinations will be much higher after in these years, and this can have impact of stunting. Indonesia have still like a very high stunting, and not only for the bottom quantile, but also everywhere. Like the latest figures, if I'm not mistaken, is around 28% of stunting. So I'm worried that those kind of impact. But of course, the other impact is like the one that probably the iceberg, like in terms of mental health impacts. This is some things that like, and usually we do not have that much public services that cater to mental health impacts in Indonesia.
Thank you. And what about human capital in terms of education and the disparities in educational opportunities? Just like you said, in healthcare, there might be foregone or delayed things. We
Mhm.
might be able to make up with immunizations, but we might not, and there might be increased gaps in who's received access or who makes up later. What about aligning incentives to try to reinvest in education and make sure that it's not a long-term impact on this generation from this crisis?
Totally. With uneven connectivity, like you see, like there are several areas where it's almost learning loss, total learning loss for some of the children. Even those with good connectivity, sometimes it is not easy, not easy to give learning to people, like stress among children, boredom, not really getting enough knowledge from just like sitting and watching webinar, Zoom without any. It can be torture for some of the children, especially for those with only in primary school, for example. At the same times, like the mother and fathers might be busy also with other things. It's adding additional burden for them. But I think going forward, of course, like we know, technology can be used better to make sure it is not just only one-way interaction, how to make it more adaptive, how to make it like more exciting for them. Combinations of that. But as you said earlier, for education, could be a generational loss. I think there is a need to ensure catching up, a lifelong learning strategy, ability to get more, to catch up with additional skills. Even before the crisis, like the digital transformation emphasized the race between skill and technology, ensuring everyone can learn, whether they are still in school and not in school anymore, is very important. Currently, Indonesia has this Prakerja program, which is giving voucher for training, but also at the same time incentive to take those training, and it's quite big all over Indonesia. Every provinces have like each year it's around 5.6 million participants. Currently, mostly through online, but later on it will be a hybrid online and offline. I think it is a good initiative to ensure like lifelong learning, everyone can catch up, everyone can take up skill and reskill. I think going forward, not only because of the pandemic, the opportunity to learn again, to take training, to improve even on the job or online or offline is very important now. And I think the other things that like very important is also inducing more collaboration between school and parents to ensure that there is like more ability when there is some, for example, what happened now, parents could also be the facilitator for learning.
Thank you. Since you also mentioned technology, I wanted to build upon that a little bit and ask you about the role of technology and data, which you mentioned, especially all these combinations of methods for better targeting and social protection and beyond. There's a lot of invitation to use technologies and maybe AI to help crunch the data and then roll it out to wider programs. I wonder what is the perception of that and whether you think it's practical and working in Indonesia, and also whether there are concerns, you know, have been voiced in many different societies in different ways, like in Korea, some people wondering what's being done with my data from these tracing apps or other places of the world. Some places embrace it more than others. So if you could speak a little bit both about the use of that in policy and beyond, and people's reaction to the issues of privacy and use of their data.
Yep. currently, I think like it's still a balance in Indonesia in terms of like Indonesia have a lot of data, but there are a lot of other potential data that can be used. For example, just to mention on targeting. On targeting, as you see, like our research shows like PMT is better, but there are still a lot of room for improvement in improving the PMT. One of the issues is like the unobserved characteristics. If we rely only from the SUSENAS data, we only have like certain number of variables that might not be correlated with the transient poverty, for example. Ability to use other big data, spatial data, utilization data to improve this model, and using more better modeling system, deep learning, machine learning can give like improvement. But of course, as you said earlier, it is important to ensure like privacy data. There is some anecdotal evidence of like breaching of this policy data. Like for example, in terms of like worried that some of the BPJS numbers actually being used by other e-commerce data to induce buyers, for example, to induce subscriptions. So I think Indonesia, both cases needs to be addressed, using more data, using better data, using deep learning data, but also improving privacy of data. Currently, the government is still talking like discussing about the privacy regulation. I think it is important so that people are not worried about like sharing their data, and ensuring that the important things like data can be the new currency. Indonesia have quite a numbers of, for example, like the startup company that become Dekakon, etc. The usage of their data usually for just like improvement in terms of their clicks. How to ensure that this usage of data is actually for addressing some of the big issues, for example, like the issues of inequality, the issues of stunting. Some of the information is probably not with Central Bureau of Statistics, the most important information, but the information is actually with this platform. Inducing, like taking the balance between we are able to use this important data for important activities, but at the same time ensuring privacy, ensuring that people like ethical consideration of using that data.
And related to that, what do you think you think the current stage is sort of evidence-based policy making in this space in Indonesia? You've seen progress over time. You have a long-term experience from the World Bank working international comparisons as well as many aspects of domestic policy. I'm curious, what areas do you think policy is informed well by evidence? Where is it not so well informed? Where has it improved the most, improved the least? And are you optimistic going forward?
So there are some good interventions, but of course, as always, there is a lot of homework. Like, for example, the good intervention, as you know, like one of the inequality issue, like inequality is a big issue in Indonesia, and government through Vice President Office since I think 2010 already established think tank within the government to ensure the usage of evidence-based policymaking. This is the NP2K, and they are the one also who push, for example, the establishing of the targeting system in the beginning, the evaluation of social protection program, and it becomes more and more, but not everywhere. So some of the programs are actually having a proper evaluation and proper plan to be evaluated to monitor, but there are still a lot of other programs with a trial and error mechanisms. On inducing evidence-based policymaking, there are some challenge here. One of the challenge, of course, data. Like as you see earlier, some of the data is like obsolete, but the other more important problem is access to data. For example, even though Central Bureau of Statistics have a lot of data, if we see from the university in Indonesia, for example, mostly use IFLS data because those IFLS is the only one that available for free. Ensuring access to data is very important here if we want to have more productions of knowledge. The second one is like more what I call the dancing between policymakers and knowledge makers. Sometimes like what being produced by the academic community is not what really needed by the public servants. For example, we do need to induce more collaboration here, understandings like the issues, ensuring access to, for example, admin data, because admin data will give us like academicians, like researchers, ability to understand better, to have proper identification strategies. The other thing is getting more support from outside in terms of translating the finding into action. Sometimes evidence, you cannot really just use showing the results of your report and then like believe that it will translate into actions. There are a lot of things that needs to be done to induce buy-in, and the buy-in needs not only from the government, from the public servants, but most importantly from the parliament and also from the society. Like the need to translate the evidence into layman language so people understands the impact. For example, fuel subsidy. There are a lot of studies about the impact, the regressive impact of fuel subsidy, but to induce willingness to reform the fuel prices, you need to have the buy-in from the parliament, buy-in from the society. So I think like three things, like access to data, better collaborations between knowledge makers and public makers, and getting buy-in from all about the importance of evidence-based policymaking.
Thank you. Yes, also important and work in synergy, don't they? Well, we can hope. My final question for you, among the ones we've gathered, is, relates to women in leadership. You've had a lot of experience and had a whole career in analyzing policy carefully, communicating it to various different stakeholders. But also during the pandemic, we've all seen how that women often are disparately impacted in terms of taking care of the children and beyond. So I wonder if you had any thoughts about the role of women in careers, girls in education and beyond. What do you think has been a significant sign of progress, and where do we need more efforts going forward?
The significance of progress we can see if we look in terms of like the education attainment in Indonesia, you do not see much difference between boys and girls. Even lately, universities, you can see that there are quite a lot of like those like a better performance of girls in universities, for example. The main significance is, of course, the glass ceilings within labor market. The discrimination, this is not only in Indonesia, the discrimination in terms of wage payment, but also the other most important ones is within parliament members. Indonesia have this quota of 30% allocated for women, but usually it is not being fulfilled. So ability to induce more on that issues. Currently, you see like quite like in terms of like the candidate majors, for example, or echelon 1 and ministers, there are prominent women ministers from Indonesia. I can say that, of course, Sri Mulyani, Ibu Retno, like it's can definitely show that women can do anything in Indonesia. But the labor market is the most one of the #1 problem for Indonesia's women. For example, inducing not only access to good occupation, but also ability to climb the ladders within the company is another issues in here. The other issues, as I mentioned earlier, mental healthness, violence, domestic violence, are some things that people are currently more acknowledging the importance of addressing those issues, and it's still far. There are still a lot of homework that Indonesia needs to do on that issues. Some other issues of women related to women is like maternal mortality, which is still quite high and much higher compared to other countries with similar trajectory and similar income. This is a big problem for Indonesia also. So labor market and in parliament and some certain health issues, including mental health and maternal mortality. But on education, I felt it's much better. Of course, like there are still room, for example, on certain type of like STEM, for example, we want to see more women participation on that. But I think it's actually, I don't have the figures. It's actually quite like the proportion is quite high.
Well, thank you for sharing such a wide-ranging series of points you made in your presentation and obligingly answered a wide range of questions. Do you have any parting thoughts you'd like to share with us?
I think like COVID is a common enemy for everyone. What needed is like more concerted efforts, not only within the countries, among countries, ensuring access to vaccine everywhere, not only for developed countries, but also for everywhere. Because if we are not able to address it together, we will still have this COVID overall. And as you said earlier, evidence-based policy making is very important. This is a wicked hard problem. Learning and sharing, learning together is very important here, so that we have like more collaboration, transfer of knowledge, transfer of technology among countries also.
Well, thank you so much for your leadership in the field and for sharing your insights with us today. And thank you all for joining us today.
Thank you. Bye-bye.
Take care and be well, everyone.
Take care.